walking into the room, I want to address my patient. Hello, Miss Gardner. My name is Abby. I am going to be your nurse practitioner today. I will pull the curtain and close the door for privacy. I want to wash my hands and then address the patient again. We see that you have moved to the city and you want to establish care here at our clinic. So today I want to do a focused heart and lung assessment on you. So we're going to start by inspecting. We are going to inspect the chest anteriorly, posteriorly, and laterally. When we are doing this, we want to note color, size, shape. We're going to notice the AP diameter bilaterally or laterally. We want to notice chest rise and fall, any use of accessory muscles. Also, while we're inspecting the chest, we want to monitor the patient's respiratory rate and rhythm. We'll do that by counting at least 6 seconds while we're noticing their breathing. So we'll do that anteriorly, posteriorly, and laterally. Then I need to point out some landmarks. So we're going to notice the trachea, and we are going to look at which is midline here, and then the substernal notch, and then underneath the substernal notch is the angle of Louis. We also want to notice the costal space here, which is in between the ribs. In the costal space, we're going to assess for thoracic expansion. So by doing that, I'm going to place my thumbs underneath the patient's diaphragm and ask them to breathe in and out. And we want to do that posteriorly as well. And we will notice that, or in a normal assessment, you would notice that the thumbs move symmetrically as the patient breathes in and out. Next, we want to palpate. So I'm going to palpate here, starting at the apex of the lungs. We're feeling in these bony prominences for any crepitus or vibrations. And we want to palpate posteriorly, starting at the apex as well, feeling for any crepitus or vibrations. And next, while we're looking at the posterior view, we are going to assess for tactile fremitus. And we do that by placing our hands laterally down the spine on each side of the spine, and the patient will say the word 99 as I move my hands.
99, 99, 99.
And I do not feel any tactile fremitus there. Next, we're going to move on to percussion. I will start with percussing posteriorly. As I percuss, I want to notice the intensity, the pitch, and the tone of the percussion that as I am moving down the back. We're going to percuss to the right and left. When we are percussing the lungs, we want to listen we'll hear dullness over the diaphragm and the heart, and you want to hear resonance over the lung fields. So we're going to do that posteriorly. Now we'll do this anteriorly, starting again at the apex. Right and left. And then we also want to percuss laterally, and we should hear resonance over the lung fields. And that was a normal exam. And now I want to auscultate the lung sounds. We're going to auscultate with the diaphragm of the bell on the patient's bare chest if this was a normal situation. So as I'm assessing the breath sounds, I want to listen for any abnormal lung sounds, wheezes, crackles, stridor. So I'm going to begin that assessment. I'm going to listen to 6 areas on the back. And the patient will take deep breaths in and out. And then we'll move towards the front. We want to start at the apex of the lung. And we also want to look laterally, or listen laterally. Okay. Okay, we have auscultated the lungs. One more thing that we need to do before we move on. I need to assess for vocal, I don't remember the last word. Vocal resonance is what we're going to listen for next. So I'm going to assess this. I'm going to listen to the lungs, and I'm going to have the patient say the word 99 again.
99, 99, 99, 99, 99, 99.
And we had a normal exam there. One more thing that we need to do before we move to the heart is we need to assess for diaphragmatic excursion. In doing this, I'm going to percuss. I'm going to have the patient take a deep breath in and blow out. And when she's blowing out, I'm going to percuss down the lung, listening for dullness. The point that I hear dullness, I will mark it with a pen. And then we'll wait a few moments, let the patient take a deep breath, take a couple of normal breaths. And then I'm going to have the patient take a deep breath and hold it. And I'll percuss again, listening for the area of dullness. And I will mark that spot with a pin. And the pinpoints between, the distance between the 2 pinpoints that we marked should be at least 3 to 5 centimeters for a normal exam. And we had a normal exam here. Next, we are going to move on to assessing the heart. So first we want to inspect the chest, the precordium. We're looking just at the overall symmetrics of the chest. We want to look for any abnormalities on the skin. Then we're going to point out some landmarks. Here we are looking at the apex of the heart here. We want to notice our sternal borders. We have the right sternal border and the left sternal border on each side of the sternum, and then the base of the heart. So now I'll have the patient lay back, and if this were a normal exam, the patient would be undressed and I'll be able to see her bare chest. First, I'm going to place the palm of my hand onto the patient's apical, the apical area of the heart. We're going to feel for an apical impulse at this time. It should be, we're palpating for any thrills or heaves. This should be soft and gentle. And then moving on, we will palpate the left sternal border here. Again, palpating for heaves or thrills. And then last, we will palpate the base of the heart for heaves and thrills as well. And that is a normal exam. Moving on, we want to feel again for the apical impulse. We're going to count. I'm gonna place my hand on the apical impulse, and then I'm gonna have the patient turn her head to the left. We're gonna feel for her carotid pulse. We want to assure that these pulses are symmetric. And here they are. We also want to count the apical impulse here. And we find a normal exam. I'm going to have the patient sit up. And now we can begin our auscultation portion. So we're going to begin by auscultating with the diaphragm of our stethoscope, again on the patient's bare chest if this were a normal exam. We're going to point out the landmarks to you. We're going to start to the right of the sternal border, which is the aortic valve, and then to the left of the aortic, or left of the sternal border, is the pulmonic valve. Moving down to the third intercostal space is Erb's point. The fourth intercostal space here is the tricuspid valve, and the fifth intercostal space mid-clavicular line is the mitral valve. So again, first we're going to listen with the stethoscope, or with the diaphragm of the stethoscope. We're listening for the heart sounds, the rate, and rhythm. So we'll do that very quickly. And here again, we are noting the rate and rhythm of those heart sounds. Next, we will turn our stethoscope over to the bell side of the stethoscope, and we are going to listen for any heart murmur or abnormal heart tones. We're going to follow that same process here. Okay, and I didn't hear any heart murmurs or abnormal heart tones, but if I did, I would want to note the location, the timing, the intensity, duration, any in coordinates with the respiratory rate, and also when we're listening to the heart sounds, the normal heart tones with the diaphragm and the stethoscope, at the aortic valve, we're going to hear an S2 sound, as well as at the pulmonic valve, you'll hear an S2 sound. At Erb's point, there's no valve there, so you shouldn't be hearing an S1 or 2. And then in the pulmonic and the mitral valve, you should hear an S1 heart tone. And here we had a normal exam. She had normal heart tones and normal rate and rhythm, no murmurs, and no abnormal heart tones. So this patient had a normal exam today. And at the end of my exam, I would ask the patient if she had any more questions or concerns or anything that I could help her better understand. I would wash my hands, and that will be the conclusion of our exam today.